acromegaly, as you know, is a disease that's caused by a growth hormone secreting pituitary tumor. And it usually occurs in patients in the middle of life, like around their 30s or 40s, but it can be diagnosed younger, in which case people get to be giants if they've get it before their bones close at puberty, or it can be very late in life. And we have some patients that are elderly with acromegaly and diagnosed even in the eighth decade. So it can be in men, it can be in women, but the feature that they all have is they all do have excess growth hormone. And the signs and symptoms associated with that can be growth of the hands, of the feet, of the head. They can get facial changes with thickening of their lips and their tongue and their nose. So even after a person stops growing because they've gone through puberty and they won't get taller, they can still get growth of cartilage and changes in their facial features, their hands and their feet. A lot of patients won't know they have this. The changes are so slow over a long period of time. They may be suffering from joint pain, diabetes, hypertension, sleep apnea, which are all comorbidities of acromegaly. They don't know that they have the disease until someone recognizes their features, or they end up going to a doctor who knows enough to put the pieces together and say, let's test you for acromegaly. So the most common ways to present with acromegaly are growth of the hands and feet, so acral changes, headaches, or incidental, meaning they're meeting up with someone from a medical professional team unrelated to their acromegaly, but someone identifies their features. So those are the most fascinating cases, and we have some great examples, for example, of one of my colleagues who had as a child lived next door to a patient who went on to get acromegaly, but when he was running for office 30 years later, she saw his picture in the newspaper and said, she was an endocrinologist, and said, oh my God, I grew up with this guy, he looks so different, I know he has acromegaly. She tested him, he had it, and he was cured. So that was a case where he didn't present with any symptom at all, but some endocrinologists recognized his features and knew to test for it. And we get examples like that where physicians are in an audience of an opera singer and they recognize the facial features. And it's always a trick of what to say and when to say it. You had asked me who makes the diagnosis. So I wanted to give you some very specific information on that, since we did do a study looking at 100 of our own patients and who discovered that they had acromegaly and thought to test them. And then more recently, there's been a study out of a European conglomerate group that has identified which doctors make the diagnosis in 3,173 of their patients. So we had very detailed charts and records on our 100 patients. They had slightly less, but enormous number of patients in the European collaborative study. And both of us show very similar findings, which is that the primary care and the endocrinologist are the two highest likely to make the diagnosis. And after that, it gets to be a large group of subspecialists, everything from orthopedists to GYN to GI to pulmonary because of sleep apnea, ENT, because of the changes in the tongue, and sometimes even in rare cases, hearing loss has been described, ophthalmologists because of compression of the chiasm, the dentist because of jaw growth, and a whole host of other medical subspecialists can all be part of this. Once acromegaly is suspected, which is probably the hardest part, this constellation of long-term symptoms, comorbidities that we discussed, or physical changes, or the patient notices that their hands and feet are changing, then the next step is to go to the medical doctor. And I think the question that you're really asking is, how do you know that they have acromegaly once you suspect it? And the answer to that is the first screening test to decide whether someone has acromegaly or not is an IGF-1 level. And that's a simple blood test. It can be done any time of the day. There's a large number of different assays out there, and some are better than others. There are some that will err on the side of saying the IGF-1 is high when it's really not. And there's others that are less sensitive and may show that it's normal, even in another lab when it might be high if there's a borderline result. So you can get discrepancies among different assays. We use the Quest assay right now. It works really well with a good solid normal range that has appropriate testing to determine it. An IGF-1 that's elevated will be the first sign that someone has growth hormone excess. And then you could go on with a confirmation test, which can be an oral glucose tolerance test for growth hormone, which is the idea that if something in endocrine is too high and we're just trying to confirm that it's actually too high, we do something to try to suppress that. And an oral glucose tolerance test is the suppression test for acromegaly. If the growth hormone is still high after the sugar is raised from giving glucose, when the growth hormone should be suppressed in the setting of a high sugar, then you know for sure that the patient has acromegaly and growth hormone excess has been confirmed. Almost all cases with acromegaly are due to a pituitary tumor. It's usually a macroadenoma, meaning a tumor that's greater than 1 centimeter, as opposed to a microadenoma, which is a pituitary tumor less than 1 centimeter. Both cases are possible, even rare cases of no tumor seen because it's so small you can't find it on the MRI. The vast majority of patients with acromegaly have a macroadenoma, and that will be seen on the MRI. And that is a pituitary tumor that looks like a lesion there, or a mass lesion, that is overproducing and over-secreting growth hormone, causing this disease. Almost all patients will have a growth hormone secreting pituitary adenoma as the cause for their acromegaly. There are very rare situations where there are alternate causes of acromegaly. And those are patients that have what we call ectopic secretion of growth hormone. That can be from a tumor somewhere else that makes growth hormone, or a tumor somewhere else that makes growth hormone releasing hormone, GHRH, which is the stimulator for growth hormone. They're both very uncommon, although GHRH secretion as an ectopic source of acromegaly is more likely than ectopic GH secretion. But in either case, you would have no pituitary tumor, but you would have an excess of growth hormone or its stimulator GHRH coming from another tumor source. Absolutely. There's a few key points that I think will be useful in terms of identifying patients earlier in medical practice. One is look at patients' hands, hands that the rings can't get off, or a patient that's had to resize their ring over several times in the course of a decade. Ask for changes in size of feet. That will be a signal, because usually feet don't really grow in adulthood. New spaces between the teeth because of jaw growth is very unusual during adulthood. So those are all signs that someone should be tested: hand growth, foot growth, new spaces between teeth in adulthood. On top of that, I think the biggest thing for primary care doctors or general physicians to remember is that when you start to get a clustering of symptoms that are fairly common, but they are all in one patient. So you have somebody with maybe earlier onset hypertension, diabetes that's getting worse, sleep apnea. That's a fairly common constellation in patients, but when you get all of those things and any of these changes that go with acromegaly, you have to think about it. Not everyone will have the classic look with a large chin and a large nose and the larger brow. It can be very subtle facial changes. So if you have comorbidities that congregate together, early hypertension, worsening diabetes, sleep apnea, you have to think about acromegaly a little bit sooner. Colonic polyps are also sometimes in the list of comorbidities there. And I've seen a lot of patients that have all of those, and they're coming to me like 10 years later with like very late stage acromegaly. And each one of those comorbidities was treated just as its own problem, not related to a single source, which is the growth hormone excess. And the final point in terms of remembering to think about this disease is in women that may look like they have a more common disease, which is called polycystic ovarian syndrome, where their periods are irregular and they get hair growth and acne. Maybe they have trouble getting pregnant. Some of these women with acromegaly have seen fertility doctors, been treated with fertility drugs, sometimes successfully. And the reason for their infertility is actually growth hormone excess, which can be a cause of a PCOS or polycystic ovarian syndrome like picture. So that can kind of fake you out and be missed easily. The other piece of history that we sometimes get a chance to see, retrospectively, is that a woman has presented with fertility treatment, then went on to get pregnant and had gestational diabetes. And that is also common in someone who has growth hormone excess that's uncontrolled. The earlier we intervene, the more likely we are to cure surgically. So microadenomas have a very high rate of cure. Macroadenomas that are more invasive have a lower likelihood of cure. So the surgery is usually the first step as long as there's a tumor that's identified. And a good surgeon is really important. So someone who has great experience in a number of pituitary surgeries would be ideal. After the surgery, we have to reevaluate that patient to determine whether the growth hormone excess is still there. That can take a little time after the surgery. You can check growth hormone right away. In fact, day 1 and day 2 post-op levels that are lower are associated with the likelihood of cure. But the real proof of the pudding will come with the IGF-1 level, which has to be done 6 to 12 weeks after the surgery. And if that's normal, that patient is in remission and can be followed. If that's elevated, or the growth hormone is elevated, or their symptoms are still there along with elevated levels, then medical therapy is necessary. And there's many different medical therapies now available to treat persistent growth hormone excess after surgical failure. So we used to think that it was just sporadic, that there wasn't really much genetics to acromegaly except in rare syndromes, but we're learning more and more that some of these cases can be familial. The ones that we have the genes for are complicated syndromes like multiple endocrine neoplasia, where there are multiple endocrine tumors, including pancreatic, parathyroid, and pituitary tumors. And they're not just acromegaly, they can be any of those cases. And that's an MEN1 mutation that occurs straight through families. So there'll be usually another family member involved. The patient could be the first one with MEN1. And so if they have more than one of those endocrine tumors along with acromegaly, they should get tested for MEN1. It's not usually found though, and we actually published a paper very recently in the JCM looking at patients with acromegaly and hyperparathyroidism specifically for MEN1. And all of our patients, there were 22 that we described, were negative for the genetic testing. So so there's other things that explain these rare cases of hyperparathyroidism and acromegaly, but if you throw in a pancreatic tumor into the mix, then MEN1 becomes more likely, or a third tumor, then it's likely to have the MEN1. Other genetic tests that can be done for cases where there's more than one family member involved as having acromegaly is the AIP mutation, the aryl hydrocarbon interacting receptor protein mutation, which has been described in familial cases of multiple pituitary tumors in one family, where you can have more than one family member that has a pituitary tumor, and that type of tumor is usually acromegaly. So if you have, for example, a parent and a child, or brother and sister, you may have an AIP mutation, and those usually will present at a younger age of onset. So they're more likely to include patients that have gigantism because they get the disease before puberty. We're still learning about other genes and trying to look for them when you have family members that have multiple tumors, acromegaly and prolactinomas, or acromegaly and other non-functioning pituitary tumors, or just acromegaly that don't have an AIP mutation or an MEN1 mutation, and that don't have Carney complex, which is the other gene involved. So there are a few rare genetic syndromes that include multiple endocrine tumors. Some of them are just a pure familial isolated pituitary adenoma syndrome, which is associated with AIP mutations, but all of those are rare. And the most common finding in a patient with acromegaly is that they're the only one in their families that have known to have it, and we don't know the genetics involved. I think to tell patients that they're not alone. I think many endocrinologists or primary care doctors will have only one patient because it is a rare disease, and like all rare diseases, it can be a very lonely feeling. I would encourage them to get seen if they have, any residual disease at all at a pituitary center. One, because these are going to be the physicians that are most likely to be aware of all the new available therapies, but also they can then join in, even when we go back to having live waiting rooms, many other patients with acromegaly. And if not, there are online communities as well for patients with acromegaly, so that they don't feel alone. And I know a lot of our patients enjoy talking to other patients right in our waiting room, since we specialize in acromegaly. And in the days when we had patients in our office, they were able to chat readily.
Yeah. Well,